My name is Erik Liederbauer, and this is my presentation, Calcium Cage, a case of pericardial calcification after cardiac surgery causing decompensated heart failure. The etiology of decompensated heart failure has many different diagnoses. Consider constrictive pericarditis secondary to pericardial calcification in patients with a history of cardiac surgery. My patient was a 70-year-old man with heart failure and reduced ejection fraction, coronary artery disease who had a bypass graft 10 years ago, and ventricular tachycardia who now has an ICD. He presented to the ED after his ICD fired at home. He was found to be in acute decompensated heart failure that was triggering VTAC. My chart review was notable for multiple admissions for decompensated heart failure that were attributed to dietary indiscretion. However, my patient was adamant about following a strict low-salt diet. Pertinent objective findings include stable vital signs, a grade 3 left lower sternal border systolic murmur, bibasilar crackles on lung exam, and an interesting overlay of pretibial myxedema and pitting edema to the knees. Point of care ultrasound was notable for an elevated JVP to 14 centimeters, a dense pericardium without any effusions, and a globally reduced EF, and his lungs had B lines bilaterally. His initial laboratory evaluation was notable for an acute kidney injury, a stable TSH, a negative troponin, and an elevated NT-proBNP. His chest X-ray had cardiomegaly and vascular congestion. I admitted this patient for decompensated heart failure and diuresed him over the next 5 days. As euvolemia was approached, his ventricular tachycardia improved. To further assess his volume status, I sent the patient for a right heart cath. This procedure was notable for an elevated right-sided filling pressure, decreased right ventricular stroke volume, and interestingly, a normal X descent but a prominent Y descent. A schematic of a right atrial pressure tracing of my patient is shown here on the right, and I'd like to draw your attention to these prominent Y descents, which is concerning for constrictive physiology. To evaluate this further, I sent the patient for a CT scan of his chest, which found these dense pericardial calcifications that predominated along the left heart border and apex, effectively forming a calcium cage causing pericardial constriction. Further evaluation of his pericardium and infiltrative diseases such as amyloid, sarcoid, and hemochromatosis all were negative. Cardiac stripping to remove his pericardium was not offered due to significant risk for morbidity and mortality. Pericardial calcifications form in response to inflammation. It is relatively rare, but when it is seen, it is usually associated with cardiac surgery, trauma, radiation, or malignancy. In most cases, it's asymptomatic, but it can cause problems when patients develop constrictive physiology. Pericardial stripping to relieve the ventricular constriction is curative, but the procedural risk comes with high morbidity. This patient's multiple admissions due to dietary indiscretion led to provider bias about the precipitating factors for his decompensated heart failure. Patients with a history of CABG presenting with decompensated heart failure should be evaluated for constrictive pericarditis due to pericardial calcifications. My patient was discharged home in stable condition with close heart failure clinic follow-up. However, over the next 6 months, he had an additional admission for heart failure, and his goals of care have shifted towards more quality of life. My references are below. Thank you very much for listening.